Start.
A very good morning to all of you. Once again, welcome to the teaching class of Department of Urology, Sahu Singh Medical College. Today, we have a class on acute kidney injury, and this will be presented by our resident, Dr. Nihal Singh, and would be moderated by our faculty, Dr. R.D. Sahu. So I would request Nihal to kindly share his presentation.
Good morning, respected teachers and everyone. Today's topic of seminar is acute renal failure or acute kidney injury. Moderator is Dr. R.D. Sahu, sir. Introduction. Definition is when there is impairment of kidney filtration and excretory function over days to weeks, usually within the 7 days, resulting in the retention of the nitrogenous and other waste product. It is not a single disease, but it is a heterogeneous group of conditions that share the common diagnostic features. That is significantly increase in the serum creatinine concentration and is associated with the reduction in the urine volume. It is a clinical diagnosis, not a structural one. Acute kidney injury diagnosed if one of the following criteria are met. These are the TDGO criteria. First, when there is increase in the serum creatinine of at least 0.3 milligram per deciliters within 48 hours and 50% increase in the baseline serum creatinine within 7 days. Urine output less than 5 ml per kg. AKI complicates 5 to 7% of the acute care hospital admissions and up to 30% of the admissions of the intensive care units. There are two types of the acute kidney injuries: community-acquired acute kidney injury and hospital-acquired. Community-acquired are because of the volume depletion, heart failure, and adverse effects of the medications, and hospital-acquired are usually because of the post-operative sepsis and major surgical procedures. Now, this is the mechanism how glomerular filtration is lost. Two types of mechanisms are there: ischemia perfusion and nephrotoxins. Ischemia perfusion causes a reduced blood flow to the renal blood flow that causes the tubular injury, and there is feedback inhibition because of the increased sodium delivery to the distal convoluted tubule that causes the reduced renal flow. And nephrotoxins causes by different mechanisms like cell membrane injury, ATP depletions, and increased permeability and mesangial and cortical vasoconstriction. All this leads to the reduced glomerular filtration rate. Now, etiology and pathophysiology of the AKI, there are typically three types of the acute kidney injury. First is pre-renal AKI, that is pre-renal azotemia. Azotemia is accumulation of the nitrogenous waste products. And second is renal intrinsic AKI. And third is post-renal AKI. This is the mechanism how glomerular blood flow is maintained. First, there are the efferent arterioles, and second one is the efferent arterioles. In efferent arterioles, there are prostacyclins that causes the vasodilatations, and efferent arteriole vasoconstriction is caused by the angiotensin II. This maintains the renal blood flow. In case of NSAID use, causes the depletion in the vasodilatory prostacyclins, and angiotensin converting enzyme inhibitors and ARBs causes the decrease in the angiotensin II that causes the efferent arteriole vasodilatation. So this leads to the AKI. Now, causes of the pre-renal AKI, mainly because of the reduced blood delivery to the kidney. Common causes are volume depletion, that is hemorrhage, dehydration, and gastrointestinal loss. Decreased effective circulatory blood volume, that is decreased cardiac output, that is congestive heart failure, myocardial infarction, and hypertension. And functional causes are angiotensin converting enzyme inhibitors, NSAIDs, angiotensin receptor blockers, and cyclosporine and tacrolimus. If we promptly correct the volume depletion, then we can restore the kidney function to normal because of there is no structural damage to the kidney. Intrinsic AKI, it occurs because of the damage within the kidney, that is the structure of the nephron. Causes are vascular damage, glomerular damage, and acute tubular necrosis. Acute tubular necrosis accounts for 50% of the intrinsic AKI. Causes are ischemia. Major causes post-operative sepsis after major operation, usually involving the significant blood loss in emergency procedures. And predisposing factors are the old age, chronic kidney disease, diabetes, type 2 uncontrolled, and emergency procedures. Endogenous toxins also causes the acute kidney injury and intrinsic renal injury. Contrast-induced nephropathy causes acute tubular necrosis. Amphotericin B Acute interstitial nephritis is caused by NSAIDs. So NSAIDs causes both pre-renal injury and also intrinsic renal injury. Pre-renal injury can also progress to intrinsic acute kidney injury if the underlying condition is not promptly corrected. Now, contrast-induced nephropathy. Definition is when there is absolute rise in the serum creatinine more than 0.5 milligram per deciliter or more than 20% relative increase in the serum creatinine from the baseline at 48 to 72 hours after exposure to the contrast agent. It peaks at 3 to 5 days, and there is absence of alternative causes of the acute kidney injury. What is KDIGO classification of the contrast-induced nephropathy is rise in the serum creatinine more than 0.3 milligram from the baseline within 48 hours of the IV administration of the contrast agent or more than 50% from the baseline over the course of hospitalization after the exposure to the contrast. Now, iodinate contrast agents that are used for the intervention that are more prone for the contrast-induced nephropathy than the imaging studies. Rise in serum creatinine in contrast-induced nephropathy begins with 24 to 48 hours following exposure. It peaks at 3 to 5 days and resolves within 1 week. Now, mechanism of the contrast-induced nephropathy is it causes acute kidney injury by hypoxia, cytotoxic damage to the tubules, and there is transient obstruction of the tubules because of the accumulation of the contrast in the tubules. Risk factors for the development of the contrast-induced nephropathy. There are two types of risk factors: non-modifiable risk factor and modifiable risk factor. Non-modifiable risk factors are the old age, pre-existing renal failure, that is GFR is less than 60 ml per minute, and low left ventricular ejection fraction less than 40%, and renal transplant. Modifiable risk factors are the hypotension, anemia, and albumin level less than 3.35 gram per liter or 3.5 gram per deciliter. How can we prevent contrast-induced nephropathy? Indication for prevention of the or therapy for the contrast before giving the contrast is pre-existing CKD with GFR less than 60 ml per minute, uncontrolled diabetes mellitus, old age patients, and severely anemic patient. Non-pharmacological therapy for the prevention of the contrast-induced nephropathy is hydration to prevent the contrast-induced nephropathy. Usually, KDIGO guidelines recommend that we should use the normal saline regimen, 1 ml per kg per hour for 12 hours before and after the procedure. And the sodium bicarbonate regimen, we give 3 ml per kg per hour for 1 hour before the procedure and 1 ml per kg per hour for 6 hours post-transplant. This Poseidon trial conducted on both these regimen. There is no difference between sodium bicarbonate regimen and the saline regimen in the benefits. Now, pharmacological therapy, these are unproven therapy. Ascorbic acid 3 gram orally given pre-contrast and 2 gram orally post-contrast, 2 doses given post-contrast. N-acetylcysteine given 600 to 1200 milligram orally 12 hourly, and control of the blood glucose level should be kept between the 110 to 149 milligram per deciliter with the use of insulin. Now, choice of the contrast for the imaging studies or intervention. Preferred contrast is iodinated, low osmolar, that is iodixanol. It has the lowest rate of the AKI. Volume should not exceed 30 ml for diagnostic procedure and more than 100 ml, should not exceed 100 ml for intervention. Now, classification of the radiological contrast media. There are two types of radiological contrast media, ionic and non-ionic, that further divided into monomeric and dimeric, and isoosmolar, low osmolar, hypoosmolar. Now, preferred agent is two agents are preferred. One is low osmolar non-ionic, that is iohexol. Trade name is Omnipeg, and isoosmolar non-ionic dimer, iodixanol, Visipeg. Both of these are preferred in the high-risk patient, and this causes low contrast-induced nephropathy. In contrast-induced nephropathy, contrast is contraindicated when GFR is less than 30 ml per minute. If it causes the systemic nephrogenic fibrosis, that is symptoms are subcutaneous fibrosis, lung fibrosis, and causes fibrosis in the heart. Now, intrinsic AKI is also caused by the antibiotics, the vancomycin, aminoglycoside, and amphotericin B. Aminoglycoside freely filtered across the glomerulus and it accumulates in the cortex. Amphotericin B binds through the tubular membrane, cholesterol, and it induces the pore. It is dose and duration dependent. Chemotherapeutic agents that causes the acute kidney injuries are cisplatin and carboplatin. These accumulate by proximal tubular cells and causes necrosis and apoptosis. Ifosfamide causes hemorrhagic cystitis and tubular toxicity. Bevacizumab, that is anti-angiogenic chemotherapeutic agent, causes proteinuria and hypertension via the injury to the glomerular microvasculars. Immune checkpoint inhibitors like ipilimumab, tremelimumab, and nivolumab and pembrolizumab also causes the acute interstitial nephritis. Now, causes of the post-renal acute kidney injuries are obstruction to the urinary outflow, that is bladder outlet obstruction, prostatomegaly, prostatic cancer, anticholinergic drugs, and ureteral obstruction. Ureteral obstruction in case of the solitary functioning kidney, malignancies, pelvic or renal obstruction. Post-renal AKI account for less than 10% of the cases of acute kidney injury. Rapid resolution of the post-renal AKI restores the kidney function because there is a without structural damage. Now, in case of the partial obstruction, we cannot rely on the urine output to diagnose the AKI because GFR is 2 orders of magnitude more than the urinary flow rate. Now, classification of the AKI. Criteria used for the AKI are rifle criteria, that is risk, injury, failure, loss of kidney function, and end-stage renal disease. Akin criteria, that is acute kidney injury network, and KDIGO criteria, that is kidney disease improving global outcome. These are the criteria for the acute injury, kidney injury. Diagnostic criteria in KDIGO we use is, as previously discussed, increase in the serum creatinine of more than 0.3 milligram per deciliter within 48 hours, or more than 50% within the 7 days, or urine output less than 0.5 ml per kg per hour for more than 6 hours. Staging, their rifle staging, rifle is risk, or stage 1 KDIGO is in rifle there is increase in the serum creatinine to 1.5 time of the baseline. And in Akin criteria, there is increase in the serum creatinine of more than 0.3 milligram deciliter, or 150 to 200 times of the baseline. And in stage 1 KDIGO, there is increase in the serum creatinine of more than 0.3 milligram deciliter, or 1.5 to 1.9 times of the baseline. Urine output criteria same in rifle, Akin, and KDIGO. That is urine output of less than 0.5 ml per kg per hour for 6 to 12 hours. Stage 2 rifle, injury rifle, or stage 2 Akin or KDIGO classification, there is increase in the serum creatinine to 2 times of the baseline in rifle, increase in the serum creatinine to 200 to 300 times of the baseline in the Akin criteria, and increase in the serum creatinine 2 to 2.9 times of the baseline in the EDIGO. And urine output criteria is same on all of the three, that is urine output of less than 0.5 ml per kg per hour for 12 to 24 hours. Failure or stage 3 Akin or KDIGO is in rifle criteria, there is increase in the serum creatinine to 3 times of the baseline, and increase in the serum creatinine to more than 3% of the baseline in Akin criteria, and increase in serum creatinine more than 3 times of baseline in the KDIGO criteria. And urine output criteria is same, increase in serum creatinine by more than 0.5, urine output is less than 0.3 ml per kg per hour for more than 24 hours, or anuria more than 12 hours, and urine output in Akin criteria is less than 0.3 ml per kg per hour for more than 24 hours, and anuria for more than 12 hours. There are 2 additional criteria in rifle, that is loss, need of kidney replacement therapy for more than 4 weeks, and end-stage disease is need of kidney replacement therapy more than 3 months. Now, course of the AKI: initiation phase, maintenance phase, and recovery phase. In initiation phase, it occurs when the time from event to sign of decrease in renal perfusion. It occurs from several hours to 2 days. It is potentially reversible. In maintenance phase, that is oliguric or anuric phase, blood urea nitrogen increases daily, and it is oliguric phase. That occurs because renal replacement therapy is required in the maintenance phase. In recovery phase, when there is return of the tubular function, blood urea nitrogen or serum create takes 4 to 6 months to recur to the normal, and there will be residual impairment of the GFR. Now, oliguria is defined as the urine output of less than 400 ml over 24 hours, and anuria is defined as the urine output of less than 50 ml over 24 hours. Now, assessment. In assessment, patient history is very important. There will be predisposing factors like disease status of hypertension, diabetes, and immunological disease, and exposure to the nephrotoxic agents. In prerenal azotemia, there will be a history of vomiting, diarrhea, glycosuria causing the polyuria, and diuretic use, NSAID use, ACE inhibitors, and ARB use. There will be physical signs of orthostatic hypotension in prerenal azotemia, tachycardia, reduced jugular venous pressure, and decreased skin turgor and dry mucous membranes. Post-renal AKI will have history of lower urinary tract symptoms, UTIs, and history of hematuria, fever, and ureteric colic. Now, clinical presentation of acute kidney injury. Vital signs of the patient will be altered. There will be hyperventilation to compensate for the metabolic acidosis. Body temperature will be altered. And physical findings of the AKI will include the signs of uremia that presents with malaise, fatigue, disorientation, or drowsiness. Color and texture of the skin will be changed. Bruising, petechie, and edema will be present. And dehydration of signs of dehydration and fluid overload will be there. Now, patient will present with peripheral edema or weight gain, mental status changes, shortness of breath, and pruritus. In the AKI, early phase, complete anuria is not common because only in condition where the solitary functioning kidney is there and urinary tract obstruction is there, complete obstruction and renal artery occlusion, then will be there will be early anuria in case of the AKI. Now, laboratory test, there will be elevated serum creatinine and elevated blood urea nitrogen concentration, decreased creatinine clearance. Blood urea nitrogen to creatinine ratio will be greater than 20:1 in pre-renal AKI and less than 20:1 in intrinsic or post-renal AKI. Hyperkalemia will be there, hypocalcemia, hyperphosphatemia, and metabolic acidosis. Now, course of the rise in the serum creatinine is different in different pathologies. In pre-renal azotemia, there will be modest rise in the serum creatinine, return to baseline with improvement in the hemodynamic status. Contrast-induced nephropathy, there will be rise in the serum creatinine within 24 to 40 hours, 8 hours, and it will peak within 3 to 5 days and resolve within 5 days, 5 to 7 days. Aminoglycoside, antibiotic, and cisplatin, there will be rise in the serum creatinine delayed for 3 to 5 days and increases up to the 2 weeks after the initial exposure. Now, that laboratory findings, there are different in the different causes. Pre-renal azotemia, their blood urea nitrogen to creatinine ratio will be more than 20%, and fractional sodium excretion that is measured by urinary sodium multiplied by serum creatinine and plasma sodium divided by plasma sodium and urinary creatinine into 100. Pre-renal azotemia will be less than, FENA will be less than 1, and hyaline cast will be there in the urine, and the osmolarity will be more than 500 milliosmol per kg in pre-renal azotemia. And sepsis-induced or intrinsic AKI, fractional sodium excretion initially will be low, but after some time it increases and it will be more than 2% or 1%, and osmolarity will be less than 50 milliosmol per kg. In post-renal AKI, there will be history of kidney stone disease, prostate disease, obstructed bladder, and retroperitoneal pelvic neoplasm. There are no significant finding in the urinary urine analysis, but we should do imaging or computed tomography or ultrasound to rule out the post-renal cause of AKI. Now, these are the difference between pre-renal azotemia and renal AKI. Radiological evaluation. Radiological ultrasound or CT scan are done to rule out the obstruction, and it will there will be hydronephrosis in the CT scan or USG. Obstruction can be present without the radiological abnormality in retroperitoneal fibrosis, encasement with tumor, and early in the course of obstruction. If there is high clinical suspicion of the obstruction and radiological findings are normal, then we should go for antegrade or retrograde pyelography. Kidney biopsy is reserved for the allograft dysfunction. The complications of the AKI. Complications of AKI mainly uremia, hypervolemia or hypovolemia, hyponatremia. It occurs because of the administration of the excessive hypotonic crystalloid or isotonic dextrose. It can cause neurological abnormality like seizures. Hyperkalemia causes muscle weakness and fatal arrhythmias, and acidosis occurs with the anion gap, elevation in the anion gap. Hyperphosphatemia and hypocalcemia will occur because of the derangement in the vitamin D, parathyroid, and the fibroblast growth factor axis. Symptoms are perioral paresthesia, muscle cramps, seizures, carpopedal spasm, and prolongation of the QT interval on electrocardiography. Bleeding and infections will be there. Now, prevention and the treatment of the AKI. Goal of the treatment is to minimize the degree of kidney insult and reduce the extra-renal complication, and restoration of the renal function to pre-acute kidney injury status is the ultimate goal. Treatment approaches. Currently, there is no definitive treatment theory for AKI. Supportive care is the mainstay management of the regardless of the etiology. Now, general issues, we should resuscitate the volume, and there should be judicious use of the vasopressor. We should eliminate the nephrotoxic agent like AC inhibitors, ARBs, and NSAIDs and aminoglycosides, and initiation of the renal replacement therapy when indicated. Now, specific issue, volume overload should be managed by salt and water restrictions and diuresis and ultrafiltration. Hyponatremia, that we should restrict the enteral free water intake, minimization of the hypotonic intravenous solutions, including those containing dextrose. Hypertonic saline is rarely necessary. In asymptomatic cases, we should only give isotonic salines. In symptomatic cases, and there is a severe hyponatremia or neurological symptoms, we should give hypertonic saline at the rate of 1 to 2 ml per kg per hour and corrected at the rate of 2 milliequivalent per liter per hour. And we should not exceed the correction more than 12 milliequivalent per liter in 24 hours. And endpoint is the 18 milliequivalent per liter in the 48 hours. And when sodium is more than 120 milliequivalent per liter, we should stop the 3% NaCl. Hyperkalemia. Hyperkalemia management is restriction of the dietary potassium intake, discontinuation of the potassium-sparing diuretics like and S inhibitors, ARBs, and NSAIDs. Loop diuretics should be used to promote the urinary potassium loss. Potassium binding ion exchange resins like sodium, polystyrene, and sulfonate should be used. We should give insulin, 10 unit regular insulin in 50 ml of 50% dextrose to promote the entry of potassium intracellularly. Inhaled beta agonist therapy to promote the entry of the potassium intracellularly. If when there is changes on the echocardiogram like widened QRS complex and symptomatic arrhythmia, we should initially give IV calcium gluconate or calcium glucuride chloride to stabilize the myocardium. Metabolic acidosis. We should give sodium bicarbonate if the pH is less than 7.2, and we should keep the sodium bicarbonate, serum bicarbonate level to more than 15 millimole per liter. And we should give renal replacement therapy in severe acidosis, that is pH less than 7.15. Hyperphosphatemia should be treated by the restriction of the dietary phosphate intake. Phosphate binding agents like sevelamer and aluminum hydroxide should be taken with the meal. Hypocalcemia, there are calcium carbonate, calcium gluconate should be given. In case of this severe hypocalcemia, that is less than 7.5 milligram per deciliter, we should give 1 to 2 ampule of the 10% of 10 ml calcium gluconate. That corrects the 90, include the 93 to 186 milligram of the calcium for bolus dose. After that, we should give 0.3 to 0.9 milligram per kg per hour calcium gluconate. In case of the moderate hypocalcemia, that is serum calcium level more than 7.5 milligram per deciliter, we should give 1 to 2 ml of the calcium gluconate, 10% of 10 ml every 4 to 6 hourly, and we should monitor the serum calcium every 4 to 6 hourly. And range should be lower normal range of the calcium up to which we correct the calcium. Nutrition, we should give a diet of the 20 to 30 kilocalorie per kg per day caloric requirement to avoid the negative nitrogen balance via the enteral route if possible. Protein, we should give 0.28 to 1.0 gram per kg per day in non-catabolic AKI, 1.0 to 1.5 gram per kg per day in case of the dialysis, and up to 1.7 gram per kg per day in hypercatabolic state. Post-renal AKI, prompt recognition and relief of the urinary tract obstruction prevent the permanent structural damage. We should insert transurethral suprapubic catheterization for urethral stricture or functional bladder impairment. In case of ureteric obstruction, we should insert percutaneous nephrostomy tube or ureteral stent placement should be there. Now, non-pharmacological therapy for the acute renal failure. We should replace the fluid by the PRBC for the blood loss, and there is no benefit of the albumin or the colloid solution over the crystalloids. Renal replacement therapy is required in case of the, there are the indication for renal replacement therapy, that is blood urea nitrogen is greater than 100 milligram per deciliter, potassium greater than 6 milliequivalent per liter, and magnesium greater than 9.7 milligram per deciliter, and metabolic acidosis with pH less than 7.15, and diuretic resistant fluid overload. These are the indication of renal replacement therapy. Pharmacological therapy, we should use loop diuretics to reduce the fluid overload. Thiazide diuretics works on the distal convoluted tubule that are not used effective for the fluid removal, but we should use both of these diuretics in combination to overcome from the diuretic resistance. Mannitol, potassium diuretics and low-dose dopamine are not recommended. And continuous infusion of the diuretic is recommended over the bolus use of the diuretic. Thank you.
Thank you, Nihal. So the topic is important in the sense that many of us would not be very vigilant or knowledgeable about this particular subject, as we usually refer this patient to nephrologist. But definitely we need to know the subject, because a lot of patients would come directly to us in the OPD, and when to refer this patient to nephrologist, when to do an emergency kind of a management, and what is the exact management. That is, again, very important for us as urologists also. First of all, the term acute renal failure is usually not used nowadays. So it's acute kidney injury, right? So by definition, acute kidney injury is a sudden or abrupt decline, which is reversible usually in the GFR, right? And there are various criteria. We have known the rifle criteria, the KDIGO criteria, and the Acute criteria. So rifle criteria, we all know, is risk, injury, failure, loss of kidney function, and end-stage renal disease. And similarly, there's a modified rifle criteria, there's Acute criteria, acute kidney injury network. And the latest one is the KDIGO criteria, which is a kidney disease improving global outcome, right? So they have divided these into various stages depending upon the increase in the serum creatinine value and decrease in urine output. So the initial risk, or the first stage in KDIGO criteria, is when there is increase in the serum creatinine value of 0.3, right? More than 0.3, or it goes more than 1.5 times the baseline, right? And the urine volume decreases by less than half ml per kg per hour for 6 hours, right? And the second stage is when it is usually 2 to 3 times, 2 to 2.9 times the creatinine value of the baseline, and the urine output decreases for about 12 hours. And then the third stage is when it is more than 3 times the baseline and the urine volume is for 24 hours, it is less than 0.5 ml per kg per hour. So you have to also understand, remember that sometimes the creatinine may not rise. So even if there is a patient who has oliguric or anuric, without rise of creatinine, he falls into the category of acute kidney injury. So if the patient has less than urine out 0.5 ml per kg per hour for 6 hours, even without increase in creatinine value, he falls into acute kidney injury. So while evaluating a case, when the patient comes to the urology OPD, we must actually know in which stage the disease is, right? So some of the acute kidney injury, which falls in the milder grade, stage 1, may be treated on the OPD basis also. But most of these 2 and 3 would require a nephrology referral, and they require a proper management. There are some cases where they require acute management in the form of emergency KRT, that is emergency kidney replacement therapy. So those cases are like patients who are in pulmonary edema, right, with breathlessness, patients of pericardial effusion, right? So patient not respond. So all these patients, and patient presenting with seizures, right? So severe uremic signs. So all these require kind of a acute emergency kidney replacement therapy in the form of dialysis. So those patients need to be referred immediately for nephrology reference. And then if the patient falls into the severe category, we need to evaluate accordingly. We all know, we discussed about how to evaluate such cases. We must know the various causes. It could be pre-renal, renal, and post-renal causes. So, but it is not necessary that they have to be always fall into one category of cause, right? They may overlap. So many of these pre-renal causes will actually result into renal causes, right? So ischemia actually may cause, first it starts with the pre-renal category, then it goes into renal, right? It causes acute tubular necrosis and all that. So they may overlap. So you must know the various causes. He has discussed the various pre-renal causes. We must know. The first important is the hypovolemia, or the acute blood loss, which may be due to hemorrhage, burns. It may be due to vomiting, diarrhea. And so all these causes acute hypovolemia and can result in decreased renal revenue. So it could be a systemic decrease in blood flow. It could be a selective decrease in blood flow, like renal artery stenosis, selective or aortic aneurysm and all that, where there is sometimes there is acute decrease in the renal blood flow. So we must know exactly all these causes. And then we need to take a proper history of the patient, which will tell us what could have been the cause of this sudden acute kidney injury. And we need to take a proper history of the various drugs. As he has enumerated the drugs, we need to, very important is that the use of NSAIDs, antibiotics which are nephrotoxic, chemotherapeutic drugs which are nephrotoxic, and even the antihypertensive drugs like the ACE inhibitors and the ARBs, which can cause acute kidney injury. So we need to take a proper history of the various drugs, and then you do a proper physical examination. So the important is the vital signs, the blood pressure, the pulse, the respiratory rate, pulse. All these are very important. And even looking at the skin of the patient, the eyes and ears are very important to find out the various signs of kidney injury. Like on skin, sometimes the patient with cirrhosis, they will have livedo reticularis, right? They can have a butterfly rash. So patients with vasculitis will have purpuric rash all over the body. Patients who are taking NSAID may have a fixed drug rash, maculopapular rash on the skin, right? And the dry skin, the pruritus. So all these are important signs of kidney injury. So in eyes, there could be vasculitis, there could be keratitis, there could be keratopathy, there could be retinopathy, hypertension. So all these are important in understanding the various signs which are produced after kidney injury, right? And then we come to the investigations. Investigations are again important. The urine routine microscopic examination, the spot test, the urine albumin creatinine ratio. That is again important. And then in urine, there are a lot of things, the CAS, the WBC CAS, the red blood CAS, and the pyuria, so all these are very important in understanding what type of injury. Then the fractional excretion of sodium, the FENA, which is also important to differentiate between pre-renal and renal causes. And then the serum creatinine values, of course, and the GFR, eGFR calculated. And then you must also remember there are a lot of biomarkers which have developed, right? Urinary biomarkers and the blood biomarkers, which can tell you about the kidney injury. Sometimes the creatinine may not rise, but these biomarkers may tell you that yes, the patient is developing kidney injury. So some of them are like NGAL, right? Then there is urinary interleukin, all right? Then there is a kidney injury molecule, KIM1, right? So all these are urinary biomarkers which are diagnostic of kidney injury. Similarly, we have prognostic markers for. So you must know all these important biomarkers also. And then when you come to investigations, yes, these urine tests and then You do a blood test, then the serum electrolyte level, the acid-base balance, acid-base analysis, and then imaging studies. Imaging studies, ultrasound is very important. It will tell you about the obstructive causes of stone. It can also tell you about the kidney stenosis, the perfusion, and even the ultrasound of IVC can tell you about the hypovolemic state of the patient. So ultrasound imaging is very important in many ways. And if necessary, we will do a CT imaging and other studies, right? So these are important to actually find out the various cause and how to deal with these patients. In the management part, we all know how to send the patient to emergency for KRT, how to refer the patient to nephrologist at what stage, and then the different management include as if there's hypovolemia, that you have to treat the hypovolemia, blood loss, you treat the blood loss. Then it comes to the electrolyte imbalance, which could be sodium, treating hyperkalemia, treating hypomagnesemia, treating hyperphosphatemia. So all these, again, are then the hyperuricemia. So these are important factors in treating management of acute kidney injury. And then you treat the metabolic acidosis part. And then you have also to know the nutritional part. So how to manage the nutritional part of that, and then how to assess the progress of the disease and the prognosis of the disease by calculating by the urine test, the fluid and electrolyte imbalance, and the physical signs. All those are important. And how to follow up these patients in, and there is a condition called AKI on chronic kidney disease also. So AKI, CKD itself is a risk factor for AKI, right? So we must know that how these patients do present, and we know that acute kidney injury is quite common, particularly it could be, as he said, the community-acquired AKI or the hospital. Hospital admissions, it has been seen that almost 7% of hospital admissions can have acute kidney injury, right? And up to 30 to 40% of ICU admissions, they do have acute kidney injury. So it's so common, and we need to actually know how to diagnose them and how to manage these patients. So thank you. If residents and faculty they have any question, please let me know. Any of you? If those who have joined us today want to say anything or give any comment, please let me know. I would have loved to have a nephrologist with us. I invited them also, but I think for some reason they have not been able to come. So I think we will wrap up here, and I would request Dr. Ardi, moderator of our session today, to kindly give his last remarks, and then we will wrap up. Yes. Okay. We have MCQs also. Right. Thank you. So we have MCQs. So thank you for reminding me. So we will just go to the MCQs. Right. Okay. So question 1. In patients with occult renal artery stenosis, ACE inhibitors cause ARF due to sudden sodium retention, increases ADH, afferent arterial vasoconstriction, efferent arterial vasodilatation. What one is? D. What is the answer? D. It causes efferent arterial vasodilatation, ACE inhibitors, right? So, and ARBs also cause the same? ARBs. So ARBs and ACE inhibitors got, so you must now understand that the selective decrease in the renal blood flow could be due to either afferent vasoconstriction or efferent vasodilatation, right? So some drugs like NSAID would cause afferent vasoconstriction. And there's ARBs, and that cause efferent vasodilatation. So angiotensin 2 has selective vasoconstrictive effect on efferent than on afferent arterioles, and drugs like ACE inhibitors and ARBs may cause ARF by efferent arterial vasodilatation. So second question, when AKI is first recognized in a patient, initial therapeutic intervention should be Begin low-dose dopamine, administer a cardiac inotropic agent, restore adequate circulating blood volume, administer a loop diuretic, begin mannitol infusion. So it depends upon what is the actual cause behind it, right? So whenever you treat this way, you try to find out the cause, you try to eliminate the insult, which has been the cause for AKI. So the insult could be hypovolemia, the insult could be the various drugs, various nephrotoxins, right? So you have to understand which has caused it and try to eliminate them. And here, if it is hypovolemia, then you have to restore the adequate circulating blood volume. So during the initial stage, a trial of parenteral hydration with isotonic fluids may correct ARF secondary to pre-renal causes, right? The major risk of MRI with gadolinium in patient with advanced chronic kidney disease is nephrotoxicity, anaphylaxis, nephrogenic systemic fibrosis, and seizures. So we all know the contrast agents that we used, normally iodinated, that have cause contrast nephropathy, whereas gadolinium as the contrast causes nephrogenic systemic fibrosis. And that is why even doing a contrast MRI would not be not optimum for patients who need MRI if they are in renal failure. So, but there are now newer contrast agents for MRI, which doesn't cause nephrogenic systemic fibrosis. So you must try to find out which are those contrast agents which would not cause. So gadolinium-based contrasts have been associated with development of this fibrosis, and at-risk patients should include those with advanced CKD. So dopamine therapy in AKI causes efferent arterial vasodilatation, is recommended for routine use after renal transplant, is effective due to improved renal function, is an unproven treatment, improves patient survival. Unproven. So we all know it's controversial now. Most of us do not give dopamine nowadays as a routine treatment in most of these patients of AKI, right? So results of clinical studies have not conclusively proved that dopamine infusion improves ARF. A patient with AKI after partial nephrectomy has serum potassium of 6.9 and widening of QRS complex of ECG. The initial step in management should be IV calcium, IV insulin and glucose, sodium polystyrene sulfonate resin, IV furosemide, and dialysis. IV calcium. So any patient who has hyperkalemia is defined as more than 5.5, and severe hyperkalemia is more than 6.5, right? So if hyperkalemia has changes on ECG, then the treatment is to stabilize the cardiac membrane by IV calcium. So IV calcium initially is given in patients who have ECG changes, right? So priorities for treatment of acute hyperkalemia with ECG changes include stabilizing the membrane, which may be accomplished with the use of IV calcium salts. True about pre-renal azotemia. Plasma, blood, urea, nitrogen, creatinine ratio more than 20. Urine osmolality less than 350. FeNA more than 2%. Urinary sodium more than 30 milliequivalent per liter. 8. So the ratio must be more than 20. So here the urine osmolality would be more than 7. So it increases, right? FeNA is less than 1%. And in renal causes, it is more than 2%, right? And urinary sodium is more than 30. And here it should be less than 30. So ideally, so this is the chart which you must remember about how to differentiate between pre-renal and renal causes of azotemia. Which of the following is not a risk factor for developing contrast-induced nephropathy? Type 2 diabetes mellitus, dehydration, hypertension, chronic kidney disease, GFR less than 60 ml per minute, ventricular ejection fraction less than 50%. E. So all the above, rest of them are actually risk factors for contrast. So diabetes, dehydration, hypertension, chronic kidney disease, all are risk factors for contrast nephropathy. We have discussed contrast nephropathy, how to define it, contrast nephropathy, and how does it peak at 3 to 5 days. It usually resolves after 7 days, right? So ventricular ejection fraction, the most potent risk factor for CIN are CKD, diabetes, dehydration, advanced age, congestive heart failure, low hematocrit, and ventricular ejection fraction less than 40%. Okay. So ejection fraction, yeah, that's right. So less than 40%, again, a risk factor. All right. True statement for management of hyponatremia is endpoint of correction is sodium more than 130. 3% sodium chloride should be used in asymptomatic cases. Slow correction causes osmotic demyelination syndrome, and correction rate 12 milliequivalent per liter in 24 hours or 18 milliequivalent liters in 48 hours. A, D. So the correction rate should be 12 milliequivalent per liter in 24 hours or 18 in 48 hours. So definitely 3% sodium chloride we do not use in asymptomatic cases. Slow correction, the fast correction causes this kind of a demyelination syndrome. And endpoint of correction is more than 120. So the more than 120 is usually asymptomatic, right? So thank you. So that was the end of the MCQs. If anybody has any question, again, any of the members who have joined us today on Zoom or YouTube can just raise their hand. Otherwise, we will just wrap up. Yes, moderator, Dr. Radi.
Thank you for summarizing AKI with very good. And well, thank you, Nihal, for this presentation. Thank you too.
So thank you very much. So all of you, I think this is very important, and I just will wish a very good day for all those who have joined us today. Thank you very much.